Ricky Henry Live.
Ricky Henry Live. Woohoo! Shout out to Ricky Henry Live.
The land on which we gather is the traditional territory of the Mississauga of the Great First Nations, and is also covered by Treaty of 13th with Mississauga of the Great. We also acknowledge the enduring presence of our First Nations, marriage and sense of the people territory. Thank you.
Good morning, everyone. What a beautiful sight to see so many of you in one room. We are gathered here as we wait for others to join us, and seeing different people, caregivers, seeing community leaders, it gives us hope. So today is more than an event, it is a call to action. Across Canada and globally, our healthcare systems are facing complex challenges, but also new opportunities. Consider this in accordance to the Canadian Institute of Health Information, CIHI. Over 50% of healthcare workers in Canada report high levels of burnout, with racialized and immigrant healthcare workers often experiencing it at disproportionate rates. Black Canadians represent 3.5% of the population, yet they remain underrepresented in leadership in roles in healthcare and overrepresented among support roles with limited decision-making power. Meanwhile, in 2023 reports by the World Health Organization showed that Sub-Saharan Africa, where I come from and where I belong and where my roots are, bears 24% of the global disease burden, but has only 3% of the world's healthcare workforce. But in the new strategy that we Africans are advocating for with the Canadian government, we are advocating and showing the Canadian government that there is an opportunity to invest in Africa, because in 2030, Africa will have the 50% of the workforce globally. So this gives us some hope in this conversation we are going to have today. These numbers are not just statistics, they are lived realities of our colleagues, families, and communities, and they reveal a deeper need to create systems that not only treat illness but also nurture equity, uplift voices, and heal injustice. That's why we are here to share stories, exchange solutions, and empower each other. Whether you're here to learn, speak, exhibit, or connect, you are part of a growing movement redefining care through inclusion, resilience, and representation. I invite you to lean in today, not just with your ears, but with your hearts, because in this room are change makers who are already building a better tomorrow, one policy, one patient, one powerful conversation at a time. Let's begin with this journey together with intention, gratitude, and purpose. Thank you very much for listening, and I officially say that the key statistics I shared should be able to drive us into the very meaningful conversation, and you're most welcome to this. And I take this opportunity to say thank you to Afro-Canadian CEO for bringing us together and your team, and I'm grateful that we are going to have a very great conversation moving forward today. Thank you.
Those of you who just joined us, just step aside the right corner. We have tea. Tea is being served. You can have some water because summer is summering. And yes, we are feeling good, happy. It's a warm day, and we are very happy and honored to have all of you with us today. Still, we are here the whole day. Remember, we have lots and lots of catching up. We have lots and lots of information to learn. We have a lot to learn. We have a lot to listen to and to network as well. This is our annual International Empowerment Conference on Healthcare and the Medical Sector, of course, organized by the new Afro-Canadian Foundation. Our CEO is here with us, Miss Kawite, Catherine as well. Wow. She will introduce herself later. She will say hi to you later. And we are all humbled to have you with us. Ladies and gentlemen, let us have a presentation from Black Cap. Introduce yourself, because apparently she did not tell me her name. That's how some people can be conservative. But it's okay, I love you all the same.
I love you too. So my name is Nicole Sukai. I'm a family doctor with the Black Hub. And so we are located in Mississauga and Brampton. And just started in the last year, and our mandate is really to see racialized patients, especially Black patients who are, sort of talked about really being compromised when it comes to their health and access to healthcare. And so the mission of the Black Hub is to provide holistic care to Black patients. And so we are accepting patients, again, throughout the Peel region. So Brampton and Mississauga is where we get most of our patients. I also do some time at the refugee shelter, if you know Spectrum. There's a lot of new patients coming in, new clients coming in from Nigeria that are refugees that stay in that shelter. And so I do 2 days in that shelter also. And so we, of course, run the gamut of primary health care, from preventative medicine. I see a lot of diabetes and hypertension given the population that I serve and the genetic risk of the population that I serve. Sometimes challenging to get them to take medications, but I try my best. I understand just sort of cultural differences in terms of expectations of the healthcare system. So it's a journey that I take along with patients. Our eventual intention is to offer social workers, chiropodists, physiotherapists, all at low cost to the patients. We also, of course, offer immunizations, and I sometimes write support letters for immigration. So there are a range of services that we offer in our primary healthcare service there. We have also a diabetic nurse. Her name is Idia. She's also from Nigeria, and so a lot of the patients that we see. I refer to her, and okay, and then what else do I have to say here? Again, if you have anyone that needs a family doctor, the waiting period is probably about 4 weeks now, although we just got a new physician also, so perhaps that will be decreased a little bit. Again, you just Google the Black Hub or Black Hub in Peel. That's our number there. It's a little bit hard to see, but the website is not more than one page. It's multifaceted, and so just call the number and ask for an intake. We don't do walk-ins or drop-ins. You have to actually go through the intake worker because we're a community health center, so we're structured a little bit differently. And then you'll be able to see one of the primary healthcare providers. We also have a male on staff. If some patients prefer a male physician, there is a Black male physician on staff also. That's it for me. I don't know if anyone has any questions. Yes.
Thank you so much for the presentation. Is it only you that only serve the Mississauga area?
Mississauga and Brampton, yeah, your area, yeah. So because we're a community health center, as you can imagine, we are funded geographically, and so unfortunately, yeah, that's the area that we're. So we look at your address and tell you if you qualify, depending on where you are.
So that would be for the people that we know who are in that area, the family condition.
Yes, and unfortunately, as you can imagine, Peel is quite vast. So sometimes, because right now we're in a temporary space in Mississauga, and so somebody coming from Brampton, it may take, sometimes I ask them, how long does it take to get to me? And they say, Doctor, it's an hour and a half. And I'm like, oh, that's quite far. But our eventual space will be in Brampton. They just leased a 5,000 square foot, a massive facility that's going to house Roots Organization, ourselves, the Black Hub, and CMHA, Community Mental Health Association. So we're a program that has 3 organizations attached, and so, but to answer your question, yeah, primarily in Peel. All right, any more questions? Sorry, I should have come in some flyers, but I didn't, but yes. Yes.
Are you okay to respond to them?
Sure.
I had a question because I think you're doing great for the community, and we are grateful, and people here would want to learn more about Black Hub, and maybe they will be able to ask you a question, but personally I have something to understand. who are refugees that you've taken and how do they get to you? Because I think it's very important. The second one is does Black Cup serve like Black communities only, or because there's some people, because of the cultural differences that you talked about, people would want to prefer Black people to work with them. And then, lastly, one thing that maybe for me and any other person here would want to know, how have you managed to solve the issue of multicultural differences in dealing with your clientele? I'm asking this because we have many leaders here from community that are dealing with the same issue, maybe could work on it. I myself, where I work, I also see it happening. How have you managed? So, because we are here to understand the best practices that are working for others, maybe that would be helpful. Thank you.
Okay, so I'll try to remember your 3 questions and I'll ask you again. So the first is talking about the refugees that we see, and actually the brunt of our current patient population comes from the newcomers to Canada and the refugees. So there is a shelter. It is a shelter because it's structured as such. And the patients, when they arrive in the airport, usually just go straight to the shelter. And they claim refugee status, I guess, in the airport. Don't know a lot about immigration, but then they go to the shelter and then navigate the immigration system. That's their starting point. Our arrangement with the shelter, and it's a 2-day arrangement where I go there 2 days a week to the shelter, and again we intake patients and we see patients. They request to see a physician, so we advertise our services there, and then the patient gets to see me at the shelter. They, however, only stay at the shelter about 3 months, and then they get, usually the sequence is they get Ontario Works, and then they get housing and they exit the shelter. Now when they exit the shelter, we don't stop seeing them, we tell them to come see us in the community. And so that's usually the sequence of, the patients coming in as refugees, and then, the struggle as all of us, if you have to migrate from one country to another, like I have, the sort of struggles about, racism and getting access to healthcare and jobs, and, you're a doctor back home, but you're not really a doctor in Canada. So all of those challenges. So we don't just do medicine, we try to, of course, address this sort of the entire person, the Gestalt person. So it's been a challenge, and so, but we try our best because we understand, and sort of addressing your question about, multicultural, we understand that coming to Canada comes with a high price that some of our patients pay, and so we try to address that. I think your second question, refugees or Black. Okay, so I think some people look at the Black Hub, and it's Black, African, and Caribbean, and so we serve the gamut. I think our mandate is really to serve Black populations, but we serve generally racialized populations. So the shelter, it's a lot of Nigerians come in the shelter, like maybe 80%, but then we have people from Pakistan and Bangladesh, and so we don't decline them services because that would be a little offensive. Also too, I'm from Trinidad, I'm from the Caribbean, and so some patients see me and they're like, "You're not Black," and I'm like, "No, but I understand the struggle. I do, I really do." And so we try to, tailor our services based on the population that we see. We don't decline anyone, even if there's a white person who wants to get services, and I do have patients that are white, but as you can imagine, primarily because we know that racialized patients have different healthcare outcomes because of the kind of healthcare that they get. We try to market towards racialized populations, and particularly Black populations from Africa and the Caribbean. And your third question has to do with, how do we, with the cultural differences. And so it's always a struggle because, I've learned that somebody from Nigeria is very different from somebody from Somalia. And, different techniques when it comes to healthcare. And so it's a learning journey and a process for me also. And so, again, we sort of tailor it by, a lot of patients are distrusting of the healthcare system, and I have a patient right now with appendix cancer, and he's declining surgery because he doesn't believe in the diagnosis, and he's asking for more and more CT scans. So it takes a lot of patience and time to talk to patients. But as you can imagine, as a physician, in my head, I'm like, we're running out of time. Like, we don't have the luxury of time, but we try, right? Because if a patient's declining surgery and you have cancer, then you can't just say, listen, there's no option. You have to do surgery. So we do take the time to talk to patients and help them understand and hold their hands a little bit, help them understand that, and address the questions that they have. And so there's a lot of variety in the nature of the population that we see. As you see, most of the patients, if they can imagine, they're refugees, they're adults that have careers and lives in other countries, and coming here, as again I mentioned, is a challenge. So we try our best to accommodate varying opinions and views, and help patients any way that we can. So we do more than a family doctor would. Like, normal family doctor wouldn't necessarily like an immigration letter of support. And we do, by the way, see also uninsured patients, and we call uninsured patients with no IFH, no refugee, no health card. Pretty much a lot of them would be in the country for 10 years, came in on a visa and never left the country. The other word people would use would be illegal, but we try not to use that word, but just so that we see those patients and we don't charge them for services, right? And so, yeah, so we spent, so I would still write letters of support. So I would do beyond what a normal family doctor would do, just because we have the funding and we have the services available. Sometimes we can get a little bit extra time to see the patients. And so I have the opportunity to help patients a little bit beyond, this is your blood pressure meds and this is for diabetes. And so, again, our intention is to just have a different flavor of family medicine. So I hope we're doing that.
So their behalf to raise their voice. So you answered some of the things that I've always asked myself.
Yeah. And so, as you can imagine, these patients that are uninsured live underground. They often work for cash, not the minimum wage that anybody in Canada would get, but they would work for $6 an hour because they have no choice, because they have no rights, because they don't exist according to the Canadian government, right? And so the beauty about our center is that we welcome those patients. Of course, we don't answer to immigration. I don't answer to immigration. So we would see them, we would ensure them there's confidentiality, and then we would order investigations. A lot of them would be a new diagnosis of medical conditions they didn't know that existed because they haven't had healthcare in 5 or 10 years. So we see them. We try. So sometimes it gets challenging. So once we had a patient with breast cancer, and then we can't afford chemotherapy, and so there are certain costs, and we are very upfront with patients in the beginning. So if a cost is going to be $30,000-$40,000, at some point because then we wouldn't be able to see anybody else, right? And so we have to sort of manage our budget accordingly, but for the brunt of preventive medicine and generalized family medicine, we can help them. But again, for the occasional person that the cost is going to be exorbitant, we try to, sometimes we would negotiate with the hospital. We would try to call the hospital and advocate for the patient and say, can you provide this service? And sometimes the hospitals actually do have some compassionate services that they offer. But if you don't have a physician advocating for it, then there's no way to get access to that. So we try as a team to ask for services for our uninsured patients. And you're right, there are pockets of people often gets ignored, and they don't have any intention, by the way, of returning home. They plan to stay here for the rest of their lives, and so at least we don't judge. We just meet them where they're at in terms of providing healthcare to them. So.
Thank you, Nicole. Am I getting your name right?
Yes, my last name is Sukai, but yeah, Nicole is my first name.
Okay, thank you so much.
Call me Dr. Nicole because my last name is
Thank you so much for such a wonderful message and the information you're letting us know. If I heard it properly, you mentioned about where you're located. You're in Mississauga and Brampton. So how about this person who is just came in, a refugee? When he came in, he landed up in Toronto. So do you have any means or any offices whereby they can register or whatever they do so that they can reach you in Mississauga or Brampton? My other question is, you talked about how you help these people with no status,
yes.
As this government say that you don't have a status. Well, do you have a particular time that this person has to stay here so that he can get those services of being helped, even though they don't have a status. Which is also, when you talked about it, it was real good. We didn't have that knowledge that someone can get those services, even though they don't have a status. But when you mentioned about it, that people can even get health, medical health and whatever, when they even don't have a status. So do they have to stay for a certain period of time? What happens? Thank you so much, Nicole.
Okay, so I'll address your second question first. And so we have an intake worker, and as you can imagine, we have a criteria for intake into our program. So the intake worker ensures somebody's not on a visa. It's coming from medical tourism. So you can't just be visiting here and expect to access our healthcare. We don't have a time period. You don't have to be here 5 days, 10 years, but you pretty much have to and you have to live in Peel, so that actually answers the question number one. You have to have an address and a postal code in the region of Peel. So it's not the time, it's the sort of qualify. So remember, the average Canadian with a health card or somebody who's a refugee with interim federal help, they can access our services once they live in Peel. You must live in Peel. So sometimes I tell patients, find an address in Peel. I don't care what that means to you, but that's the only way to access, again, because of funding. And when you learn more about community health centers, you'll know there's one in Scarborough that will not see patients from Mississauga, right? So the Scarborough patients, and so if patients are living elsewhere, even if they're refugees, we say call the community health center in Scarborough, call one. Although we do things a little bit differently, but you know, there's always a community health center in a geographic region in Ontario that will see patients for the most part. And so, so geographically, that's a little bit of a barrier. But going back to your question about qualifying, if you are uninsured and you have no status in terms of your visa has expired, and any of those sort of, some people are also on student visa, not just business visas. We do not see student visas, so you really have to have eliminated or run the course of any sort of official documentation, and then we will accept you into our program. So we of course we want people to assimilate. We want people to, so we don't punish people for, it's just that our funders dictate that we're truly just trying to eliminate people that are here on a visa that got diagnosed back home with something quite serious and then come in to get access to the healthcare here. Try to dissuade patients from doing that and then go back home, by the way, after. But most of the we hardly have a problem with that. A couple of times patients have been, they arrived last week and wanted to get healthcare services, and then as you can imagine, for the entire healthcare system, that's not something that you would have access to. But we encourage, because I tell patients, if you want to make it here, you got to go back to school. You got to, because you're a dentist back home, you have to, there's no way around it, right? If you want to be equated here. And then again, the challenges of, my parents came here, had to go back to school, they were accountants.
For example, going to school, what kind of this official documentation? So, assuming my visa is expired,
yes,
I came as a visitor, yes, but I managed to apply maybe in a school or in a college, and I have that ID of that college, and yes, I also have an address. Do I qualify for those services?
You will qualify for our services. So we of course we want people to assimilate. We want people so we don't punish people for, it's just that our funders dictate that we're truly just trying to eliminate people that are here on a visa that got diagnosed back home with something quite serious and then come in to get access to the healthcare here. Try to dissuade patients from doing that and then go back home, by the way, after. But most of the we hardly have a problem with that. A couple of times patients have been, they arrived last week and wanted to get healthcare services, and then as you can imagine, for the entire healthcare system, that's not something that you would have access to. But we encourage, because I tell patients, if you want to make it here, you got to go back to school. You got to, because you're a dentist back home, you have to, there's no way around it, right? If you want to be equated here. And then again, the challenges of, my parents came here, had to go back to school, they were accountants and nurses back home, and so I understand that patients, I don't know, if they fed a meal of life is maybe easy here, But it's a big eye-opener when they arrive and they realize that it takes a lot of work to make it in Canada. And so we have those conversations, those upfront conversations about what it takes to succeed in Canada. And sometimes it's 2 jobs. Unfortunately, it's just the nature of life in Canada, right? To be able to afford rent, because Ontario Works doesn't give them enough in the beginning anyway to be able to afford a place of their own. So sometimes they share with people, and of course there's conflict when they share. So there's a lot of little hiccups along the way that I'm hearing trends and patterns that I try to tell the patients is, finding a job. And so we offer services like that too to help them find jobs and integrate and assimilate in Canada. Again, not easy, but we try to find ways to help the patients. So.
Okay, I have a question. For example, if somebody was living in a shelter,
Yes.
but then found housing somewhere,
Yes.
when you go out there, you do not have a family doctor.
Yeah.
Because at times there are doctors who come in the shelters occasionally, maybe twice a week or something like that. So do you have any contacts, like, for example, if somebody is living in Toronto here,
Yes.
do you have contacts of doctors who you would refer them to? Do you have like a network? Because it's quite hard here going to, there's some cases where you just can't walk in.
Yes.
You understand? So do you have a network where you can refer someone, or you can give us some references of doctors, family doctors who could be accessible?
Yes. Yes. So again, we're part of the Community Health Center, and it sounds like a generic term, but it's not. It's a term meaning that we are funded for geographic areas. And let's say I see a patient in Mississauga, and now this patient has moved to North York, which has actually happened a fair amount of times, because they get housing in a sitting area that's for them relatively cheaper. And so I don't disconnect from the patient until I found them someone else, right? Although I do tell them, it's going to be a long way coming to me. And they say, yeah, doctor, I'll travel for 2 hours to see you. And I said, you may change your mind in February. You may change your mind in winter. So, going back to your question, so we do what we call an inter-CHC transfer. So if somebody's in North York, if you guys ever heard of Black Creek Community Health Center, so we would transfer the patient from a LAMP or Black Club. We're part of LAMP Community Health Center, and then we would do an inter-CHC transfer from one physician to another in the Community Health Center if the patient wants to. Because sometimes they say, oh, you know what, doctor, I found somebody that's 10 minutes away from me and it's really convenient. And I say, great, I will give you a copy of your charts, of course, at no cost, and then you can continue seeing the doctor, make sure you follow up with your blood pressure because you absolutely have a chronic condition that needs to be followed up with. So we never abandon patients and never cut ties with patients. Some patients do come to see me and it's very far away, and every time I see them, I struggle with, do you really want to do this for 2 hours? And then they say, they tried other doctors and it's just a little bit different because they have sampled a different kind of medicine and very caring and compassionate. And to go to a walk-in clinic where they just stand up and ask you what's wrong and write your prescriptions, it's a different, as we all have experienced that. They would travel if they feel that they're getting quality health care. And so, we have an internal network of physicians that we refer our patients to. We never abandon the patients.
Thank you so much. We have another question. This is beginning to get very interesting.
Thank you, Nicole. My question is about the safeguards you have for the undocumented people. They're always in fear of deportation.
They are, for sure.
And they're always in fear to stand up for their rights.
They absolutely are.
And I have access to quite a number of undocumented people that I know.
Yes.
What safeguards do you have in place to win your trust so that they can walk to you and share them? Begin the journey to make their status legal.
Yes, so I think that's probably one of the biggest barriers in accessing healthcare.
And the second one.
Oh, let's do.
The second one is, in the transition period
Yes.
of their status,
Yes.
how would you mitigate that period in transition? You've managed to sign them onto your program.
Yes.
How do you mitigate that safeguard, especially employment protection? Thank you.
So to address the first question, so safeguards, I think I'm gonna answer your question. So, you know, when I'm not the first point of contact with the patient. It's usually an intake worker that spends about an hour with the patient, explaining very clearly our confidentiality rules. And so even if somebody is undocumented or has no status, they still have access to healthcare that guards their privacy, right? So I don't, the fact that they are undocumented and have been here for 20 years is not information. As a physician, I'm bounded by the rules of confidentiality. So I just can't call and share that information with anyone at any time. I've never been in a situation where there's been a warrant and somebody's called from immigration to ask me. It's never happened. We safeguard the information just as any family medicine clinic would, or any physician would. I hope that answers your question. So there's no output of information unless the patient gives consent to. And let me give you an example. So if I'm referring a patient to ear, nose, and throat doctor because they have a lesion on their tongue, the patient will give me consent to send their information, because it's beyond my scope now, right? To send their information to an ENT doctor. I guess there is an inherent trust in our system, but we don't betray trust in terms of the patient's information. There's no outflow of information unless the patient gives consent to. I hope that answers your question. Safeguards, that's the way I can answer it as a physician. I'm bounded by my college and keeping their information very private, unless of course they say they are going to harm themselves or someone else, then the rules change a little bit. Sorry, your second question had to do with
employment protection.
Employment. Okay. So when they come in, also, so we don't have a social worker yet, but we have someone that deals with the sort of social work aspect, including employment and all of that. One of the visions for the hub is to have access to legal services for the patient, and so that like legal aid. And so usually we refer out to legal aid if patients are having immigration issues or employment issues. Of course, sometimes they don't qualify for it, and we are not an expansive organization when it comes to giving legal advice, right? So we are primarily a primary healthcare facility. So if there are patients who come and say, you know what, doctor, I'm working as a cleaner in somebody's house. Often those are the jobs, the cleaners, and also taking care of like babysitting or nanny. And they would say they treat me really bad. They pay me $8 an hour. I actually don't have a legitimate solution for that. I do not. Because they don't have access to a lawyer, remember they don't exist. They don't exist on paper in terms of being able to have the same rights as going to an Ontario Human Rights Tribunal or the legal options that we would have. And so their intention is to stay hidden. And so there are other ways to solve the problem. Like, so for example, if somebody's having food insecurity, we do have access to give them gift cards for like $50 a month to help with food services. And so I can't solve the employment challenges. It's not something that we're funded to do, and not necessarily in our mandate, you know.
So do you think that's a gray area for you?
It is a gray area.
It's a gray area for you.
Yes, yeah. I mean, if anybody has solutions, we're willing to partner, but it's just, so as you can also imagine as a family doctor, if somebody's bringing in their their employment issues, and I chart in, the average Canadian, let's say you come in and the average Canadian says to me, or somebody with a health card says to me, you know what, I'm really stressed out at work. And I say to them, oh, you have benefits? Let me write you a sick note for 2 weeks. I can't do that with somebody who is, if I offer them that, they don't get paid, and then they struggle to survive, right? So it is an inherent problem, and I don't have an easy solution. I don't have a solution. Unless you do. Yeah, so and by no means am I saying we're perfect, but the challenges that come along with being uninsured, again, we try to support people any way we can, but sometimes you can make it worse by saying you have all of these rights, or you have access, but you actually don't. So Perhaps in the future when we partner up with Legal Aid, maybe we will be able to direct patients to what other services they have, but for now, we keep our feet firmly planted in primary healthcare. But again, if patients, I'm also a thinking intellectual being, and so I direct patients that I think is what's in their best interest, right? And can they complain about their employer? To whom? To whom are they going to complain to, right? It makes it difficult.
What's your average turnaround time?
To see patients?
Complete the cycle for status.
So remember, we don't, so we just formed about a year ago, right? And so the journey of, you mean from getting from refugee to get, I don't know the answer to that question because I haven't been around patients for longer than a year. But I will tell you, if in the year, I haven't seen anyone say to me, oh doctor, now I'm landed, now I have status. It certainly not a year. And from my understanding, it doesn't take years sometimes, because a lot of the patients come on humanitarian, LGBTQ or violence in their home country, and so it's quite variable, I think, how long it takes, but no one has ever completed that journey yet to tell me how much time it actually takes. I don't know.
Oh, thank you so much. That has been very, very interesting. You've given us some insight. You've given us a different perspective of how you navigate to healthcare, and we really appreciate it. An applause for her, please. Thank you so much. Thank you.
Hi, Ricky Henry Live. Ricky Henry Live. Woohoo! Shout out to Ricky Henry Live.